Hello my friends, welcome back to my channel with a new video. Uh, there was a gap in between and I did not publish any video for the last month or so now, but again we are back and I'm starting this series with a topic on overview on acute pancreatitis. I would like to give credit to Dr. Shubhangi Kamble for this particular presentation. She is head of the department emergency medicine at KIMS Manavta Hospital in Nashik. So without further ado, let us start with this particular talk. So I'm starting with a clinical case. It is a 66 years old male, hypertensive, history of abdominal pain with nausea and vomiting since last 2 days. That patient was admitted in outside hospital with severe metabolic acidosis, as you could see, altered renal functions, and of course very high amylase and lipase, so 938 and 430 respectively, with the CT scan suggestive of acute interstitial pancreatitis with gallbladder calculi. MRCP, which was done in the next days, which did not show any calculi and it was labeled as acute pancreatitis. It was treated with IV fluids, antibiotics, analgesics, and developed breathlessness and hypotension, and was shifted on oxygen and noradrenaline support. This patient came to us in the ER, and in the ER he had low peripheral pulses with cold extremities, uh, tachypneic. Patient was put on NIV, hypotensive, sugars were high, and the noradrenaline drip which was started, and ABG was corrected with backups accordingly. IVC was assessed, which was about 2.1 centimeters with less than 50% collapsibility. He had bilateral crepts, B lines, ascites, almost no urine output. He was started on meropenem. CVP was inserted, vasopressors were started, and then shifted to ICU under my care for further management. So this is a clinical case scenario, and uh, it just brings us to the fact that what is acute pancreatitis. So it is nothing but, as we know, that it is a vital organ responsible for production of digestive enzymes and hormones regulating the blood sugars. So acute pancreatitis is acute inflammation of pancreatitis, and presentation is most of the times heterogeneous, progressing differently among different patients, and it is often unpredictable. So it's a leading GI disease requiring hospitalization worldwide, and about 80% would have mild clinical course, whereas about 20 to 30% would have a severe course and have significant mortality to the tune of about 20 to 30%. There's a whole lot of list of the etiology, starting from the gallstones, the alcohol, and hypertriglyceridemia forming the big three. Mind you, the triglyceride levels needs to be about 1000 milligrams per deciliter for it to be called as hypertriglyceridemia induced pancreatitis. Most of the times I see my friends labeling it as this particular cause, even if the triglycerides are marginally raised, say about 300 or 400, but it is not the case. You need to have the level of above 1000. Then there are different drugs. I have seen one case of L-asparaginase, then it's post ERCP, post trauma, viral, autoimmune, and there's a whole lot of list. But I think we should actually not forget the big three, and of course post ERCP and post viral. Especially we had COVID, and we have seen so many cases of pancreatitis post COVID. Now, as far as the pathophysiology is concerned, it is predominantly acute inflammatory process, which involves a parenchyma of the pancreas with involvement of other regional tissues and distant organs. Inappropriate and the premature activation of digestive enzymes, that is trypsinogen within the pancreas, which leads to the destruction of the secretory cells, followed by systemic release of cytokines, and there is a cytokine storm like situation with SIRS. Other factors in the pathogenesis are calcium overload, mitochondrial dysfunctions, impaired autophagy, endoplasmic reticulum stress, edema of the pancreatic and peripancreatic tissues, and fat necrosis, which are common in all forms of acute pancreatitis. They can be either mild, moderate, or severe. In the severe pancreatitis, there could be a possibility of hemorrhage within the pancreas. So, this is the pathophysiology as we should know. Now, there is a intrapancreatic activation of proteolytic enzymes, which leads to the local inflammation in the form of leukocyte activation, the cytokine release in the form of IL-6, TNF alpha, and IL-1, and it leads to SIRS, as we know, the systemic inflammatory response syndrome, and of course it leads to increased capillary leakage, the fluid accumulation in the third space, ileus and the GI losses of the intravascular fluid loss. Of course, the patient will have hypovolumic and the distributive shock, and ultimately they will land up in multi-organ failure. So this is the chronology of the sequence, and this is the clinical presentation. The classical abdominal pain, which is epigastric or left upper quadrant pain, which is constant with radiation to the back, chest, or flanks, and it can have severity of intensity which is varied in nature. The serum amylase and lipase, which are greater than 3 times the upper limit of the normal. Lipase is more specific than amylase, as we all know. And the characteristic findings from the abdominal imaging, initially the sonography or the focus, which we can do, but ultimately after 48 hours it is CT scan. And of course, we know that amylase versus the lipase, that we have the amylase which is secreted by many tissues other than the pancreas, and it rises with a few hours after the onset of the symptoms, and it returns to normal within 3 to 5 days. Lipase, which as I told you is more specific and remains elevated for longer period of time. Mind you, both amylase as well as lipase does not have the diagnostic significance as a serial measurements of both of them, but in any case it will have a prognostic value. As I said, they can be elevated in the variety of non-pancreatic diseases, and for them to call a significant rise, the upper limit of normal greater than 3 to 5 times, which is needed. Once the diagnosis of acute pancreatitis is established, there is no reason to follow the serum amylase and lipase, because as I said, they don't have any impact on the severity or the diagnostic approach, but they will definitely have bearing on some bearing on the prognosis. So my friends, here I would like to stop, and let's meet in my next short video on acute pancreatitis as the continuation. That's all for now. Bye.